I'd like to thank you all for coming, and I would like to say that we are delighted to be here to talk about AI and women's health, elevating women's health. And we would also like to petition for a request. That is, women are the last panel this year, and we'd like to petition to be the second or third or fourth next year. Yeah. We love this guy, but really. Yeah, right. It's all right. Strongest can be first, too. Okay, we're honored to be here. Around the world, women's health care is in a period of transformation. Advances in AI are going to give us new tools to identify disease, personalize treatment, and to live longer. Yet these innovations also give us profound questions. AI systems are only as good as the data. What goes in comes out. So if data has bias, and it's based on race, geography, even gender, socioeconomic status, the technology may widen the gaps that we see today. Miriam Vogel, who's the CEO of Equal AI, which has been studying this for years, simply sums up the dilemma. With AI being used in intakes and for symptom diagnosis, it can too often miss the symptoms of those less represented in the data. Importantly, it can even begin in the teams that are building the systems. So we have a wonderful panel here today, people that have had decades, I won't say anything about age, but decades of experience. And we have our chaperone down at the end, Dr. Moses, thank you. And we're all going to discuss various aspects from where we're coming from. Zulma Gilla, where are you? There, right there, is the founder of a really cool new invention, and it's more than cool, and it's being innovated. It's developing a benchtop blood analyzer for rapid and precise diagnostic testing in women's health. You've written, Zulma, that precision medicine must be globally inclusive under the UN's SDGs. The question, that's another story. The question is, could you explain in your own words, not only what that phrase means, but tell us a bit about, if you can, about what you're working on.
The last 8 years, I have been fully dedicated to...
Microphone up, please.
Oh, yeah. Sorry. So, as we know, going to the basic of biology, women's health are like strongly led by estrogen. So the one portion of estrogen that leads our life from 12 years old to premenopause is estradiol, where I have invested a very large amount of resources supported by top experts in the field globally, have been on the impact that estradiol has in our lives due to how, due to the complexity of this biomarker. It's not easily available to all because it has a very large range of the impact. It's the same biomarker. Is the one that leads hormonal-dependent carcinomas for breast cancer, ovarian cancer, and also is the one that leads infertility. Therefore, and also our moods, premenopause, menopause, pretty much leads our life for a very good amount of, for a period of our life. Therefore, I decided to put all my energy on aiming to bring to all corners of the world for every woman that to understand, to have access, like providing equal access to all, even if you need to understand what's happening with your health, either if you are in Madagascar, if you are in Africa, or if you are in Alaska. So my goal is to bring a mini Mayo Clinic to each corner of the world, just miniaturized. Diagnostics, everybody says, I develop point-of-care diagnostics. It's the same box from the outside. The one thing that matters based on my clinical experience, is not the box of how pretty it is the accuracy. Accuracy is everything in diagnostics. This development is based on the compliance with laboratory gold standards, and I'm trying to bring top accuracy to everyone.
How is
that's
that
it.
going to apply? I'm going to ask some questions, but we really want to hear your questions, so we'll be there. How does that apply to every woman, I guess, or man in this audience?
We all have, females and males, we all carry estradiol, we all carry estrogen and testosterone. That is how we balance our physiology. Women that have high levels of estradiol, unfortunately, are the ones that face conditions such as PCOS, endometriosis, and also at the point that infertility, many times that females, we face infertility is due to a high, on the percentage when the ratios that are expected between estradiol and testosterone, the testosterone levels are above the standard. And then in order to treat this percentage, it's like a wide amount of therapeutics. That's why I call that my development is not competitive to diagnostics, it's adjacent to therapeutics. That's why when a female is going through an IVF cycle, right on the point of care like this, the physician is able to identify if the dosage is correct, if it needs to be changed or not, with the sole purpose of increasing the percentage of successful IVF cases, that the success of the IVF cycle. My apologies.
Great. Okay.
That's it.
Now, Dr. Mosa, you're there. We are pleased to have you on this women's panel. We've all heard from you today, but you're the senior clinical engineer at Mass General Hospital. Tell us about AI solutions within the hospital setting, particularly on women's issues, and what your vision, this is all in 5 minutes, what your vision will be for the next 5 years.
Okay, I must have done something very, very well to be in this panel, so thank you so much.
He's perfect.
So-
Perfect.
So, as far as the design of AI models, 3 to 4 years from today, there will be more AI-trained models, solutions coming out of high school projects than you have ever imagined. And mark my words. I put $100 on that, and hopefully in C3 2029, 2028, I'll be able to come with high school projects out of AB classes that come with creative AI solutions. And this is, in my opinion, still a bubble. Just as the bubbles that we had in 2008, 2009, with applications that are coming in from smartphones. Because all of those solutions are being built in what we call in engineering trained closed loop or open loop systems. You feed the model bunch of informations, and based on those informations, the model is being trained into specific algorithms, different differential equations, and there you go, you'll have certain outcomes. Or in certain points where AI thinks they're a lot more smarter and there is something totally crazy they call unsupervised AI solutions. So the design of those models is always based on the programming or the design of the actual solutions based on whatever data is being there. And in order to build a successful model, you have to build it based on technical expertise, clinical expertise, and some basic science expertise. Usually teams will come in and collect data and so on and so forth. But the problem is basically the type of data that were used initially to program those models or to train those models. Are those data coming from Boston? Because that's a place where intellectuality is high, there is a lot of work and research and innovation. Your population sample is totally different. Is it based in men? Is it based in women? Is it based in a certain age group? Is it based on folks who are coming from a specific part of the world with a type of genetic diseases or a type of skin issues based on their colors, the environmental surroundings that they live in, et cetera, et cetera. And that creates what we call bias in data. And that's a problem that happens with medical devices. I'm sure a lot of folks heard about the issues that we had with SpO2 sensors during COVID, right? White patients were showing a certain oxygen saturation readings versus patients with darker skins, because the averaging of those biosymptomatic sensors was based on the data were collected during the time of the design of those sensors. And the majority of the people who went and volunteered to those research studies were white people, or people who had lighter skin color. So that was an issue. So a patient would have an oxygen reading of 93, 94, while in reality, their oxygen level is way lower because there is an average. And I don't want to get to the technicality behind that. A lot of those problems will come, but that would require a lot of awareness, a lot of work in the background. AI is not going to solve every problem that happens in healthcare. I work in one of the, Haytham, probably Dr. Hassoun is going to pick up on this. I work in one of the best hospitals in the world. Now that as a test to that testimony, they took our Tom Brady of healthcare, Dr. Peter Slavin, to the hospital. And yet, in a hospital like ours, where we're leading the interoperability of medical devices, we're writing the standards and the guidelines to teach the FDA and the industry, you would walk into our cardiac ICU, and we have patients in ECMO machines, and yet the cardiac surgeons would have to go to the patient room and read off the monitor, and we have a nurse or a nursing assistant at the bedside monitoring the activities that are happening with that patient. We cannot get data directly into the electronic medical record. And problems like this have to be solved in order for we'll talk about the deployments of AI solutions, but problems of that nature needs to be solved, and we have to utilize those AI solutions to cover those basics. And I will yield in here, and we'll get to the point of the deployment later.
Perfect, thank you. Now we're going to hear from Paige Peterson. I'm not sure how I describe Paige. She is a writer, an artist, a longtime officer of the prestigious Huntsman Cancer Institute, and she's going to offer some personal experience, which really gets down to something we've probably all experienced to some degree. Paige.
Thank you. I'm not a medical person whatsoever. So there have been so many wonderful speakers today, so I'm not going to talk from that perspective. So one of the things that I have participated in the C3 conference for 14 years, and this is the most women that have ever attended, and I'm so thrilled about that. Not only from the audience, but from the panelists. So I am so happy about that, and I agree, we can't be the last one next year. Ransel, can't be the last one.
We see you, Randall.
Okay, so I'm going to talk about a personal experience. We talked about this, and this is the best use of my time because there's so many brilliant people here. I can tell you what my time is. I'm 70 years old. When I was 40 years old, I sort of lived at Sloan Kettering for 10 years. So these are two experiences that I've had at that time. And all the boys in the room need to forgive me right away. I was diagnosed with a brain tumor. And I explained my symptoms And there were 5 doctors across the country, neurosurgeons, that told me I should see a psychiatrist. That because I had gone blind had nothing to do with the brain tumor that I had. The pain in my face had nothing to do with it, and that I was an hysterical woman. I begged them, I said, I can't take the pain anymore. There must be surgery. So I actually had to sign off as voluntary surgery. And Dr. Frazier did this at New York Hospital. And he did brain surgery. I had a meningioma that was wrapped around my sagittal sinus at the top of my head. And, several hours later, he came out of surgery and said to my mother and my sister, obviously, I was in ICU, I wasn't there, and he said, well, thank God she's an aggressive woman. She had 6 weeks to live. Every single one of those doctors would have killed me because they all said, let's take another MRI in a year and we'll watch this. You're not, you don't need this. Okay, number 1, that happened. 2 years later, I was diagnosed through a blood test that I had thyroid cancer. A doctor at Sloan Kettering, head of the department, said, you don't have thyroid cancer. And I said, well, you know what? I don't care. I've just had brain surgery. I want you to take the thyroid out. So he said, you're going to have to sign off. Fine, I'll sign off. So after he came out of surgery, he leaned over me and said, you didn't have cancer. You did not need this surgery. I said, well, I'm really glad I didn't have cancer. 4 days later, he called back and said, you have stage 4 thyroid cancer 3 times in each lobe. There was never an apology. The arrogance was astounding. So when I thought about what am I going to say here to this room, first of all, I'm 70 years old. All of this happened 30 years ago, so you guys were a little more arrogant than you probably are today. But with that said, I think that AI and men together and women together, they will be able to do a better diagnosis of people and perhaps not insult women as much as they do. I ended up being Thank you very much.
The living miracle.
I'm a living miracle. I found out later that I had something called Cowden syndrome, and I'm sort of the poster child for Cowden syndrome. Cowden syndrome is you have a burst ovary, a meningioma, stage 4 thyroid cancer, uterine cancer, tumors in your hips, and I had them all for 18 months in a row. And I was continually told that I was ridiculous. Now, in retrospect, people have talked about my life as a medical person, and in the end, I ended up at the Huntsman Cancer Institute because John Huntsman liked the fact that I was talking about attitudinal healing and how you have to stand up for yourself. So I believe that from a patient point of view, I think that AI is going to go along beautifully with the men and women in the medical world, that AI is going to be really helpful. I'm delighted by it, but I also know that through human nature, it's a practice. So this is a wonderful thing to have at our disposal.
Thank you, Paige. It's remarkable. What a story and perseverance and women's will. Okay, last but certainly not least is a real firehouse here. Dr. I'll pronounce it Manguia, is doing remarkable work. As somebody who represents the World Health Organization, which was just docked $500 million for this year because somebody pulled out of it, that would be the United States of America pulled out, I am hearing every day about what's going on in Africa. It is heart-rending. We have no idea because we're trying to keep up with what's going on here. But it is just the end of the world for people, particularly women, particularly pregnant women, particularly with AIDS, and on and on and on. So we have a representative here, the founder and CEO of the Africa Investment Consulting Firm that's dedicated to enhancing health systems and sustainable development. Our question for you, Doctor, is as a global leader in health, in patient privacy and data ownership and commercial incentives, how do you see AI contributing to all that you do?
Thank you. Those are very great questions. Sorry. And I don't think we have really the time to talk about all those things. But I want to summarize a little bit so that every point that we talk today, I mean, our platform is compassing of the platform of the panel of others talking about data, etc. For me, for us, AI is not a panacea. AI will not solve all our problems, but AI is certainly something very transformative, something that is here to stay, and we need to learn how to live with it. For people of my background, and I want to say a little bit, I work in West Harlem, I work in Brussels, I work in Nigeria, and I work in the Congo. AI will be transformative, but in order for it to have an impact, we need to backtrack a little bit. There's a lot of things, a lot of layers that need to be put in place before even we see the result. It is about awareness of what is it AI. This is something that we need to have across the population to know about what we are expecting from AI. Some of the things that I would like to talk about here is that about representation. So we talk a lot, AI is based on data. What is really the data? I'm not going to mention about what was said early on. Until recently, most of the data were collected on male, but we are applying them on female, which lead to misdiagnosis, which lead to a lot of side effects. AI can resurface those, like we said a little bit earlier, those common side effects that we haven't looked at. I want also to discuss about when we talk about AI here, we come under the perspective of people living in the Western countries where you are very well-funded, but where the trend is going when we want to invest on women's health, because women's health is not only reproductive health. Women's health has to do with cardiovascular, has to do with immuno disease, like lupus, like diabetes. It's not only fertility or menopause. It's very important to stress on that because most of the population that we are looking at, the growing need, the trends will be certainly in the southern part and the Asian part. So if we focus and we put all our resources and all the data are collected in the northern part, we're missing a lot of it. Something else that it's very important that I wanted to stress here is about education. We say in order to build data and to create those math algorithms, we need talent. How can people in the certain part who are not trained in terms of technology will be able to feed and to know about the technology? Education has a big role to play here as well. Then I would like to mention about the problem of the representation of the women. The healthcare is mostly male-oriented, but we see more and more female getting into that field. This is a good thing because we know better what our life is, what our problem is. So the leadership, and we have seen when you have more women taking decision or being on the platform, the outcome are probably better. Another things I want to say and mention about what Judith said, yes, indeed, a lot of help, a lot of financial support has been withdrawn from the north to the south. You know what? This is a good thing. This is a good thing. Yes, of course, there will be collateral. People will die from this and that. But this is the unique opportunity that we do have today in the South to really, because we have our back against the wall, to really look at innovative solution. Do we have the money? Oh, yes, we do have the money. I work with a lot of nonprofit, and I don't want to say the name. We have a lot of great philanthropists in Africa, wealthy, and they are looking at, because now we have the back against the wall, they are putting the money up front. So what we are needing from you, it's about collaboration. And then I'm turning the point to Moses, and I say collaboration, bringing all the stakeholders around the table, but the South-South collaboration is key because we don't want to model on what the northern part has done already, but we want to model, not to invent the cycle, but we want to model close to, what happened into the South is mostly a little bit the same like us. We eat the same food, the culture is, I don't say the same, but it's more close. So when we look at the AI, yes, AI will change life. It has changed life in different fields. Medical field, it will do it. We are probably literally flying the plane as we drive it, as we build it. It's okay, we will make mistakes, but we are also open to look at other people, and the South-South collaboration is gonna be very key for us.
Doctor,
Accuracy.
I just want, if you can just hold it 1 second. You could certainly finish, but I want to get questions from the audience, which we never seem to have time for. So is there anybody with a question? Got to be a question. Yes.
My son married an Asian woman who makes soy a daily part of the diet of the family. And she has a son who's eating this soy-based diet every day. And I understand that soy is high in estrogen, and I was wondering if there's someone who could respond to whether that is harmful to a young boy growing up to have high estrogen diet.
Okay, who do we have in the estrogen field? I'm looking at someone there. Zhu?
I'm an OBGYN, but I cannot really answer that question. I wish I will tell you, but even though I could, it's too personal. Here it's a confidential. And as you know, even AI, a lot of patients go into those apps, and then 1, 2, 3 minutes later, they see some advertisement selling them all kinds of things. The privacy matter here, and I want to respect your privacy, and I also want to raise the concern that we do have about privacy and using AI. We particularly, somebody earlier talked about, we feel more confident about exchanging information and etc. I don't think so. We have very rare disease in Africa. One of them is sickle cell disease that you also share with us. We are dealing with genomic here. We are dealing with something very personal. This is at the level of national security. So we don't have to take it very lightly. When we talk about AI, we need to know who we address, the privacy, who owns the data. I don't want to go into that because it was already, all my answers were said before, so I don't want to repeat it again. Yes, there's some guardrail put in place. with AI, they are not optimum, but we need to trust now that as we're going into that direction.
And the doctor will be around to personally answer your question if you'd like. Yes, sir. We have a microphone coming to you.
Yeah, I've been in around 11 pharma companies in my 30 years. I also did due diligence. But I think the ecosystem needs to change. It's more of a comment, but also how it's being looked at it from a business perspective. So basically right now, the issues is it's being looked at, the health, preventive health, well-being, clinical trial participation in Africa, in the Middle East, and other areas are not representative of some of the clinical trials as well. So that needs to change. There's a big reliance on venture capital in the U.S. and the big, pharma markets to only fund business strategies or products that make the most sense. But, there's other countries like Saudi Arabia and others that are starting to look at innovation, across the board in collaboration as well.
Question would be?
So the question is, with the panelists here, how do you see, guys, how are you changing the system to have clinical trial participation in female healthcare across the board in health, well-being, things that do make a difference now? Postpartum depression.
We have an entrepreneur here who has self-funded because of the importance she knows.
I think that like medicine is a very demanding career that when you get involved, medicine overall, medicine, bioengineering, this type of medical specialties with a direct focus in medicine, when we get into this field is because mainly, I'm open for judgment here, but it's mainly for passion. Because the amount of hours, the amount of dedication that it requires, money cannot afford it. So based on that, the reason why I mainly, the core reason that I have never publicly shared it yet, that I did this full development of MedTech, then I also did a full development of multiplex, overseeing granulosa cells. The core reason was for estradiol. Estradiol, besides being the lead of hormonal-dependent carcinomas in females, also infertility, was a study published by the Brain Society at the Davos in this past January, that it reflects the impact that estradiol also has in anxiety and brain health, anxiety, schizophrenia, all these type of conditions. So my personal the way that I can justify how people get involved in doing these innovations many times are for passion. I started it based off a tragic situation that happened in my family, and then I wanted to fix myself, and that has no cost. So I put all personal funds and personal contacts, and the beauty of this, what I haven't shared yet, is that every time I share this with someone well-known in the field, and a specialist, like head physicist in Harvard, head of biochemistry in Yale, or everyone, the common response is, or was, how can I help you? Right now, they are part of my team. Like, that is the beauty of this field. Just believe in what you're doing, and the right people will help the system for a better, to make the society better. That's it.
Dr. Mosa, I think you have something to say.
Okay, so the business of research and coming up with creative solutions for the greater good of humanity is not a very profitable business all the time. So there always should be money coming from public institutions, from governments. Policymakers have to invest in that, so solutions will come. I gave an example about the sample where ether was discovered at Mass General. Edison believe it or not, was not a rich person. And because of all the experiments and the hard work that he did, we have the lights that we're enjoying. And a lot of the inventions are occurring because of some hard work that was done and conducted by the scientists. So that's really the niche. And we cannot stop public money from going to academic institutions and research hospitals, because that's going to be nothing but a disaster. That's going to push humanity many, many years behind. Yes, venture capitals and investors and banks, they're always going to look after their profits. Their profit margins is a big driver. Like personally, I wouldn't go and put my money or retirement money into something that I'm not sure that I'll get some returns, because God knows in how many years I will retire and I need to eat. I need to pay my bills. But institutions or governments around the globe can do that. And to your point about the Kingdom of Saudi Arabia or the GCC, is a totally different situation, because in that part of the world, in the Arabian Gulf or in the MENA region, there is a different type of perception, different type of culture. The healthcare and education is a right for the citizens over there. So that is why governments are taking the full responsibility to support not just the patients, because that's just a band-aid. If you send a patient to Cedar Sinai to get treated, or to Mass General, to the Qatar Salon, those are temporary solutions. But the long-term investments have to come from states and policymakers. Then we'll see the fruits of innovative solutions.
Yeah, I think we've seen we can't really count entirely, as we have over the last 70 years, on governments. I mean, the private sector now has to kick in, because there are billions of dollars that are being pulled out of NIH and so on. It's a pendulum. It'll come back. 2 more questions. I've got one in the back here. Yes, ma'am. We got a microphone coming there.
Thank you. I'm concerned that AI is not inclusive enough, even with respects to women, because when you look at what happens with women of color, African American and Latinas, the statistics are exponentially worse. And so clearly with maternal and child health, with triple-negative breast cancer, inflammatory breast cancer, we get it earlier, suffer more, die sooner. So unless that AI data includes all the sectors of women, it's not going to be given enough information to make the right decisions and improve health outcomes. So those disparities have to be addressed, and I'm hoping that'll be a part of the data gathering, that it is more inclusive.
Doctor, we're going to ask you to respond, and then real quick,
Yeah,
because I want to take
quickly.
another question.
This is a very good question. You know what? We need to be on the table to answer those and look for those solutions. If you give to somebody else the right to search for you, to prescribe for your medication, you see, and to invest, I don't think you're gonna not even change the needle. This, you need to appropriate yourself your problem, because you yourself know it. Okay. Train more girls, train more doctors, look like you, more psychologists, etc. Hedge fund who look like us. This is my last question, my answer.
Do you mind if I?
Real quick, and then we'll
I'll
take one
just
more.
take one minute, because I'm a proud Latina too, so I'm part of the minority. So I think AI, like I'm supportive of AI in this section, as AI will just at the point of that we do the collection of unpersonalized patient data, like we put just our race. Our personal information is completely deleted, but we are also responsible to ensure that when we have to do our labs, when we have to do our studies, that we show up. Last year was a study done here in Harvard with a former professor of mine, where it showed that the Hispanic community and followed by the African American community was the 2 communities that have the highest absence to showing into the labs. Therefore, we also as citizens disregarding of our race, we are accountable to show up when we need to. So we can make our data count, because accountability has to start by us also. So it's education at home. We need to follow our labs. We need to follow whatever is required by the medical community. So our results also can be included as a community and make them count. So that is...
Okay, so I can only say, I guess we don't have time for one more question, but that having spent 50 years, 50, in Washington, we need to understand that to get back the commitment that governments and people have to AI, to women's health, to health in general, and to world health, we need to have the right people there and in state houses and so on. That is my, my unsolicited ad. I hope that we are all conscious of the great work that's going on in women's health, and I hope that we as a group can sometime in the next year, over the next year, or the next 3 years, really work together to really make women the force that they are, So thank you for coming, and we'll see you again. I'd say same time next year, but maybe the morning of next year.
Do have one.
Well, I don't know. I want to thank you for being the anchor here, because you did a great job, and I promise I'll put you at the bow next year. How's that? Oh, yeah. No, you all were great.